So at the outset, thanks for the organizers for this invitation. The topic allocated to me is the surgical techniques in glaucoma. So in 30 minutes, we can't cover the entire spectrum, that is the techniques and the complications and management. I thought mainly I will cover the surgical technique and some of the complications that can happen because of the glaucoma surgery. So if you take open angle glaucoma, the options we have in a routine practice is a penetrating surgery such as the trabeculectomy, or a non-penetrating surgery or a glaucoma drainage devices. Whereas if you look at the angle closure glaucoma, you have little more options. The options are mainly to modify the angle, such as the pupillary block relief with the iridectomy or widening of the antechamber angle when the lens is mainly contributing to the cause, like lens extraction. Or if the angle is closed with the synechiae, you can consider what we call it as a goniosynecholysis. When you are looking at the filtration, that is either you have to go for the trabeculectomy or the glaucoma drainage devices, you cannot consider a non-penetrating surgery in angle closure. If you look at the childhood glaucomas, again the childhood glaucomas are mainly because of the angle dysgenesis. Angle surgery, either the goniotomy or trabeculectomy is the answer for it. When these don't work well, then we consider the filtration surgery, that again trabeculectomy with the trabeculotomy or the drainage devices. So why do we do surgery for glaucoma? It is a most powerful IOP lowering tool we have. Resources for surgeries are widely available and a reasonably safe procedure, but you should remember it does require good amount of training and it needs very intensive post-operative follow-up to make the surgery successful. So when do we do surgery routinely? In routine clinical practice, routinely we go for the surgery when the medications are not effective, or when you anticipate the possibility of a failure for the surgery, especially in advanced glaucomas where the intraocular pressures are very high. When you feel that the medications are not going to bring down the pressures, you do go for the surgery. Some people may prefer that when they have difficulty in using the medication. There are certain conditions when the complaints is poor, side effects are severe, when the socioeconomic problems dictate terms, then you may have to go for the surgery earlier than anticipated. And one should choose appropriate technique, and we have to discuss in detail with the patient, plan the appropriate techniques, and we may have to consider antifibrotic agents and the wound modulation. The trabeculectomy still is the most commonly done glaucoma surgery, but the major cause for the failure of the trabeculectomy happens to be excessive healing at the conjunctiva tenens fascia episcleral interface. What can we do to reduce this kind of scarring? There are certain risk factors that contribute to this kind of scarring. So you have to identify those risk factors like neovascular glaucoma, aphakia, uveitis. In such people, you should plan the antimetabolites. Conjunctiva may be inflamed, especially in the present era where people are using anti-glaucoma medication for longer period of time. Certain drugs like alpha agonist and topical carbonic anhydrase inhibitors can cause allergies, and that may contribute to the scarring. During the surgery, one should remember good hemostasis, minimal diathermy, good wound closure will minimize the scarring. In the post-operative period, use of the topical steroids. If the scarring response is more, consider 5-FU injections. So routinely we tend to use the antimetabolites, and the most common being the mitomycin C. But should remember there are potential problems with it. One should use it more carefully, and wide area of the application will minimize the complications associated with the mitomycin C. Any intraoperative complication can lead into failure of the glaucoma surgery. Please remember that means the surgery has to be very meticulous. How do we do it? So preoperatively, what can you do? Control preoperative intraocular pressure with the systemic medication. Avoid hypotony at the time of the surgery. A good wound closure is important. Control wound healing response, and as I mentioned, achieve large drainage area. Usually it is done under local anesthesia, and traction suture is important to have a good exposure. The next step is a conjunctival flap, use of the antimetabolite, a scleral flap dissection, internal ostium, iridectomy, flap closure, conjunctival closure. These are the steps. I'm not going to go into the details of every step. 2-3 points are important that needs to be emphasized. So one is the conjunctival flap, whether to go for the fornix based or the limbal based. Fornix based, technically easier, better exposure. That is the trend nowadays because it tends to give more posterior flow. And limbus based is technically difficult but offers very wound closure. So when you choose to do the fornix based, be prepared for possible wound leaks in the postoperative period. So whenever we do the conjunctival opening, dissection is extremely important. It has to be very careful dissection. Use non-toothed forceps. Keep conjunctiva moist all the time, and when you are using antimetabolite, make sure the edge will not touch the antimetabolite. Ensure tight closure at the end of the suture. The scleral flap shape doesn't matter. What is important is the depth. It should be 1/2 the scleral depth, and uniform lamellar dissection and gentle manipulation using a good instruments. And whenever the sclerostomy is done, make sure that the sclerostomy is in the center, and either side there should be sufficient scleral flap available, and try to bury the suture knots, and make sure you can use a releasable sutures to close. That will help in wound modulation, or the buried sutures, if you make a note which is the tightest in the notes, you can use laser suturelysis in the postoperative period for the wound modulation. Iridectomy, a broad, wide, full thickness iridectomy is important. Postoperative management, basically IOP measurements, bleb evaluation, uses topical steroids and cycloplegics, and intensive industrialized care is critical because we don't know who is going to have severe scarring and who is not going to have severe scarring. And we tend to look at the bleb area, presence of the microcysts or any leakage, and bleb height and vascularity. And by doing gentle massage, look into the flow into the bleb. And I will be showing a short video that will tell you the steps of the surgery. And a word about the laser suturelysis. It is a very useful tool, but it should be done within the 2 weeks window period because that is the time the scarring will be maximum. When we use the antimetabolites, you can even do it beyond 6 to 8 weeks time. Good exposure of the suture is important. As I mentioned on the table, you should make a note which is the critical suture. So if you cut that critical suture, that will give you the maximum benefit out of this. And you can use any of these lenses available. These are the settings, but remember to cut only one at a time. If you tend to cut more sutures, you will end up with the complications. Complications can be conjunctival burn, subconjunctival hemorrhage. If there is excessive flow, it can lead into hypotony and leak sequelae or even hyphema. And we did talk about it. Number of surgical procedures in general have come down because of the availability of the drugs, but the long-term usage of the drugs have caused a problem in a different way because of the allergies and surface disorders. The tendency for scarring is more, so we tend to use more of antimetabolites along with the glaucoma surgery. And it's a quick video clipping that shows the fornix-based trabeculectomy. The flap being made, a good undermining, a good amount of diathermy, mitomycin C. You notice that many pieces are used to apply it for the large area. A uniform incision to make a triangular scleral flap. Dissection has to be meticulous and uniform. You notice here the sclerostomy is in the center. There is sufficient space on either side. releasable suture to the apex so that the flow will be posterior when you remove the releasable suture in the postoperative period, and 2 sutures at the base, and conjunctiva should be closed. This is how a limbal based trabeculectomy will look. You can notice that there is I don't think it's working. And this is a fornix based trabeculectomy where there is a diffuse bleb. A word about the non-penetrating. Viscocanalostomy is one of the, which one? This one. Okay. It does not require external filtration. A deep sclerectomy ends in the formation of the conjunctival bleb, and antifibrotic is often required. In comparison to the trabeculectomy, complications are less, but effectiveness also is less. Most of the time it requires goniopuncture for many patients. The key to the non-penetrating surgery again is a deep dissection, and deroofing of the Schlemm's canal is the key to the success for the non-penetrating surgery. Quickly about the tubes, it should not be implanted as a primary procedure. Even now we believe that, and should be considered when the trabeculectomy is unlikely to work or is unfeasible or very high risk for postoperative infection. One should consider tubes as the primary procedure. And a quick video, again a conjunctival dissection 2 millimeters from the limbus, a good undermining and priming of the Ahmed valve, placement of the plate almost 8 millimeters from the limbus and securing it with a non-absorbable nylon sutures 8 millimeters from the limbus. Once it is done, trimming of the tube and using a 23 or 24 gauge needle, entry into the anterior chamber, and the tube is placed into the anterior chamber. Once it is done, the tube on the surface of the sclera should be covered with a donor sclera or a donor cornea. If both are not available, one can go for the dissection of the sclera, but it is recommended to use a donor tissue, because even if it gets exposed, it is not at the cost of the patient's sclera. Then the meticulous closure of the conjunctiva is mandatory. And this is how the postoperative picture. You can see a good bleb with the tube in the subconjunctival space well covered. Quickly about the cataract and glaucoma, because nowadays most of the glaucoma surgeons manage both together majority of the times because of the phacoemulsification. The success rate of the combined surgery has improved. And they also coexist together for the individual. So whenever we look at the glaucoma and cataract, there are several issues. What is the severity of the glaucoma? What of the risk of the postoperative eyepupil spike can have it on the already compromised disc for the patient? What is the extent of the cataract? What is the size of the pupil? What is the zonular integrity? These things has to be charted out well before planning the surgery. What are the options we have? We can do just the cataract surgery and continue the glaucoma medication, or you can do the filtering surgery, later you can do the cataract surgery, or you can do both together, that is the combined cataract and glaucoma surgery. When do we do only cataract surgery? If the glaucoma is mild by definition, when the patient is on maximum of 1 or 2 drugs, the 2 drugs which can be given as in a combination, we tend to do only cataract surgery and manage the glaucoma with the medication. The best option in that is a clear corneal phaco is the best option. And if phaco is not feasible, if somebody is going for the small incision cataract surgery, it is better to do it in a temporal quadrant so that you will leave behind the superior quadrant for the possible future trabeculectomy. What are the risks one can anticipate when you do only a cataract surgery? So the spike that can happen in a compromised disc can be an issue, and the risk of the AAON also should be kept in mind. So you have to take all precautions to minimize such possibility. Cleaning up the viscoelastic. There are some studies that have shown intraoperative myotic will take care of the postoperative IOP spike. So, or routinely you can give systemic Dimox. And other option is to do the filtration surgery first, then do the cataract. But cataract surgery removal improves the vision, but it is at a risk of worsening the filtration. So preserving the blood becomes an important thing. Ideal again will be clear corneal phacoemulsification. Post cataract surgery, you can consider 5-FA injections to minimize the scarring, or one can go for the topical steroids. This is the slide that shows the pre and post cataract surgery in a pre-existing bleb. So when do we do the combined cataract and glaucoma? Indicated when there is a significant cataract, an uncontrolled glaucoma, patient is on multiple drugs, moderate or severe glaucoma damage, or borderline and inadequate bleb already present where it is likely to fail, then you go for trabeculectomy with the cataract surgery. Combined surgery is convenient, visual rehabilitation is faster, postoperative IOP spikes can be prevented, but remember the filtration that you get with the combined may not be as effective as trabeculectomy alone. And as I mentioned, they are more often seen together, so modern surgical procedure improves the success rate, especially the phacoemulsification. Phacoemulsification with the modulation, wound modulation has improved the surgical success rate. So we tend to do a scleral tunnel, I tend to do a single site, a conjunctival opening, mitomycin C application, a scleral tunnel almost 2.5 millimeters from the limbus. After the routine phacoemulsification, a sclerostomy using the Kelly sponge, and closure of the wound and closure of the conjunctiva. A quick video, mitomycin C is being applied, and you see that after thorough irrigation, and diathermy application, a scleral incision is made almost 2 to 2.5 millimeters posterior to the limbus. A tunnel is created. The routine cataract surgery. Many times you will have very dense cataract in these individuals because glaucoma patients tend to defer surgery for longer period of time. The routine lens implantation. Then you use the Kelly sponge to do the trabeculectomy under the same scleral flap, followed by iridectomy, and closure of the flap, whichever technique you feel comfortable. You can use the releasables like the trabeculectomy here. And the conjunctiva should be closed tightly. Whether the fornix based or limbal based, it is again your choice. Use of antifibrotic, usually we tend to use the mitomycin. One side, two side is controversial. Both techniques have shown an equal amount of success. It's not going to offer any advantage one over the other. And this is one of the patients with the phacotab. You can see the diffuse bleb, well placed the intraocular lens. Small pupils are often seen in glaucoma patient. It may be because of the myotics used in the past or the posterior synechiae, especially with the angle closure glaucomas, or it may be just because of the senile meiosis. Preoperatively, we have to evaluate very well and make a note of it that helps you to offer good surgical outcomes. So dynamic evaluation, that is what is the pupillary reaction. Following the dilatation, you have to look at how much the dilatation is, make a note of it. That is the static evaluation of the pupillary mydriasis. And use good viscoelastic that offers a good amount of mechanical stretching of the pupil. Or one can use go for the iris hooks or Beeler pupil dilator, or you can go for the Kuglin hooks pull and push technique. Zonular dehiscence may be related to the trauma. It may be because of the pseudoexfoliation like Dr. Ramakrishnan was explaining. Or we tend to see what we call it as a loose lens in the angle closure glaucoma. There is no actual subluxation of the lens. The looseness of the zonules contributes the lens to move forwards, resulting in the angle closure. Very often you tend to see these eyes on the table. You will realize when you try to make the rexis, you see a dimple that is going, that goes deep in when you are trying to initiate the rexis. That tells you that possibly there is a loose lens. You should be prepared for the possible consequences. So when we manage cataract and glaucoma, various factors influence. Decision should be individualized. And I will skip this and go for some of the complications in the next few minutes. So it's not possible to cover all the postoperative complications, but I thought there are certain things one should know when we deal with the glaucoma surgery, like trabeculectomy, the bleb leaks, the possible blebitis, bleb-related endophthalmitis. Unless we detect these things on time, the complications are going to be very significant, can even lead into blindness. So bleb leak can be immediate or late. So most of the time in the immediate postoperative period, because we tend to do the fornix-based conjunctive flap, the edge wound is the cause for the, whatever precautions you take, there will be some amount of leak in the postoperative period. The other reasons for the bleb leak will be undetected buttonholes during the surgery. That's why I said the meticulous trabeculectomy is very important for the success of the outcome of the surgery. Or it may be because of the postoperative wound or conjunctival dehiscence for various reasons. And antimetabolites in trabeculectomy has increased the bleb leaks in the late postoperative period, especially with the mitomycin C. And it was more common with the limbal-based flaps because we used to get very localized thin cystic blebs with the limbal-based flaps. With the larger area of application of the mitomycin C, with the shift to the fornix base, we don't get the localized blebs, they are diffuse blebs. The leaks have come down, but we still see them, and like what you see here, the one on the top is a localized bleb and causing the leak in a central area. This needs attention. And what will happen when there is a leak? You can have a shallow antechamber, you can have ocular hypertony, and depending upon the severity of the leak, there can be choroidal effusion, and in the late postoperative leaks can lead into endophthalmitis. Most of the time, endophthalmitis is related to the bleb leak. And also remember, the late bleb leak can be failure for the trabeculectomy. That trabeculectomy fails with the leakage of the bleb. And what are the signs? As I mentioned, when you measure the low intraocular pressure, please, that indicates that you have to look at what is happening at the bleb. Again, shallow antechamber. The bleb may be shallow or flat. So how do you assess? What is important is to do the Seidels test. So take a strip of the fluorescein, apply it thoroughly over the surface of the bleb and look for the leak. Okay, that's how the Seidels will be positive. So when you see a bleb with a low pressure, please do the Seidels to look for the possible leak. In the immediate postoperative period, how do you look for the leak? So good magnification and pay attention to the edge of the conjunctiva at the limbus. So keep on increasing the magnification, then you do see like this, you can see a retracted conjunctiva that is very common with the fornix-based flap causing the leak. So how do you manage in the immediate postoperative period? You can either observe or use the aqueous suppressants. The flow of the aqueous is reduced. Most of the time we tend to use the bandage contact lens, leave the bandage contact lens. Only thing you have to remember is whenever the bandage contact lens is given, you have to look at what is the type of the steroid patient is using. If it is like turbid, like prednisolone acetate, it may not be an ideal. You have to shift to the like betamethasone, which is a clear liquid. Otherwise the deposits will become an issue. Or if the bandage contact lens is not available, simple patching also will help. In the late bleb leaks, one can consider giving a conjunctival irritating topical antibiotic, people tend to give gentamicin C. But we haven't seen any success with the use of it, but the literature suggests that. And in the immediate post-operative period, reducing the topical steroids is not ideal because you need a good amount of steroids for success of the trabeculectomy, or you can use a direct suturing if the retraction is significant. And in the late post-operative period, if it's not healing, you can consider autologous blood injection. Still not effective, it requires a surgical revision of the bleb. A word about blebitis and trabeculectomy at an inferior site has a higher risk for the blebitis and endophthalmitis. Antimetabolites in trabeculectomy has increased the chances for this complication. Full thickness procedures are at a higher risk. One can divide the blebitis into 3 groups. Bleb infection, mild, when do you call it mild? When the bleb infection but no antechamber or vitreous involvement. A moderate infection when there is bleb infection along with the antechamber involvement. Severe infection is when the vitreous also is affected. And this is how the blebitis will look. You can see the yellow coloration of the bleb. And mild, how do you manage? It is an ophthalmic emergency. You should take a conjunctival swab, start the intensive topical antibiotics, and careful monitoring. We may have to see 2 times a day. We should not hesitate, and almost every day. And moderate one, again, it is an ophthalmic emergency. Admit the patient, treat as mild grade, plus start the systemic antibiotics. More careful monitoring is required. When do you say it is, when we see a severe one, again admission, topical plus systemic antibiotics. We may have to take your vitreoretinal colleagues' help in managing these. The antisegments may not be able to manage because the vitreous also is involved. And one may have to go for the antechamber paracentesis, give the intravitreal injections. If it is not responding in 12 to 24 hours time, we may have to go for the diagnostic and therapeutic vitrectomy. This is a medically managed blebitis, the one I showed before, how it has cleared with the 5th day treatment and has totally resolved with the appropriate treatment. Patient education is very important when we do trabeculectomy. Every time when they come to see you following the trabeculectomy, you have to educate the patient. What I tend to tell the patient is, unnecessarily don't touch your eyes, don't rub your eyes, don't use the pools which are likely to be contaminated. Any associated blepharitis has to be taken care. Any associated dry eye has to be taken care because these are all the predisposing conditions for possible infection. Not only for infection, when patient has these conditions, they tend to rub their eyes without realizing. Any conjunctivitis is an emergency, patient should report immediately. And they are not suitable candidate for the contact lenses. There are reports where people have started giving prophylactic antibiotic drops, but it is not a good idea because they tend to develop resistance for the drugs. So over a period of time, if you keep on changing the antibiotic, when the need comes, none of them may work for the patient. So these are some of the thoughts about the possible complications one will face when we do the glaucoma surgeries. Thank you. Thank you very much for your patient hearing.